Dear all, welcome to today's session titled The Border is Not the Boundary, Cross-Border Surveillance and Regional Preparedness in MENA. This event is part of Preparedness Beyond Borders, a regional virtual panel series focused on epidemic preparedness and surveillance organized at the American University of Beirut. This panel launches the series by placing cross-border surveillance and regional coordination at the center of the preparedness agenda. My name is Jafar Tfaili. I am the Epidemic and Pandemic Preparedness Manager at the Global Health Institute, and I'm honored to open and moderate this discussion today. This discussion aligns within the Global Health Institute mission, established in 2017 to shift the global health toward a model where Global South not only implement, but also design and lead context-driven solutions. Within GHI, the Epidemic and Pandemic Preparedness Program is one of our core thematic programs, focusing on creating tools and interventions in the MENA region to enhance the preparedness of health systems against pandemics and epidemics. To set the frame for today's discussion, disease does not observe political borders, as we all know. In a region defined by protracted conflict, mass displacement, and large-scale population movement, this is not an abstract statement. It is an operational reality. As millions of people cross borders across MENA every year through formal crossings and informal routes, displacement corridors, and transit zones. And yet the surveillance systems we rely on to detect epidemic threats early were largely designed for settled, documented populations moving through official channels. The result is a persistent gap between the populations most exposed to epidemic risk and the systems built to protect them. Today, we want to understand how deep the gap is, what drives it, and what closing it would actually require. We will run two rounds of linked discussions. In the first round, we will build the foundation, understanding where the systems fail and why. In the second round, we will see what effective cross-border surveillance must look like and what the region needs to prioritize. It is my pleasure to introduce our speakers for today's session. We have with us Dr. Mahmoud Migdadi, who is the experience in border health, cross-border surveillance, public health emergency preparedness, and health systems strengthening. His work focused on improving regional coordination, expanding inclusive health service development settings. We have also with us Dr. Muhammad Awad Ibrahim. He is a public health specialist with 18 years of experience in disease surveillance, outbreak response, and disaster management. He currently leads the rapid response team coordination and act as the head of the emergency preparedness department, focusing on strengthening capacity systems and outbreak response and the health emergency and Epidemic Control Directorate at the Federal Ministry of Health in Sudan. We have also with us Ms. Farah Masoud, who is a MENA Program Manager at California, San Francisco, where she leads regional initiatives to strengthen disease surveillance, epidemic intelligence, and public health emergency preparedness across the Middle East and North Africa. Dr. Migdadi, let's start with you. You work on the ground in Jordan, a country that hosts one of the largest refugee populations in the world relative to its size, with people moving through both formal border crossings and informal routes. Based on your experience working with displaced and mobile populations in Jordan, what does the current cross-border surveillance system fail to detect, and why does these gaps persist?
Thank you so much, Jafar, for the introduction, the panel, and also for this important question. Actually, I can mention that from our experience and on-ground work in Jordan, I can begin with one central point. Let's say the surveillance systems are generally, let's say, designed to monitor diseases within while, let's say, the lives and movements of the mobile population, let's say, more complex and difficult to deal with. Relatively developed surveillance structures and significant experience managing the population mobility and the displacement component, and also, let's say, the health emergencies, including preparedness and response. However, in let's say in such context, we have a lot of blind spots that are still remaining, and the system is not able actually to deal with. And also, let me say, let's say, focusing on the first blind spot is the system may detect a disease after a person reaches a health facility, but it often doesn't actually adequately detect the risk developing throughout the person's mobility journey. So a displaced person may move through several communities, go to transit locations, informal accommodations. There will be a several, I would say, steps until he reached to the official point of entry, or let's say the health facility. So let's say the reception facility or the health service at the end receives the case and have something to, let's say the surveillance information is usually collected as a specific facility or administration location without, let's say, capturing where the exposure occurred or how mobility contributed to the risk. Also, another blind spot is that early signals among people who do not access formal health services, usually migrants, refugees, vulnerable groups on move, mobile populations, let's say with any definition, may delay seeking care because of cost, also sometimes lack of documentations, health access issue, limited knowledge of available services, and this is very important actually, especially during the last or the recent, let's say, population mobility events. And also sometimes it is about fear of consequences and transportation barriers. Sometimes actually, and we are shocked that it's language barriers. And I know that, let's say, almost like everyone is speaking Arabic in our region, but still, we are seeing that there's sometimes some speaking or, let's say, language barriers that are impacting the whole process. So at the end, the surveillance system relying primarily on hospitals, primary healthcare centers, clinics, border health centers, and they receive the signal only after the condition becomes severe or after transmission has already occurred. Let's say the first warning signs may actually appear like elsewhere through community health workers, pharmacies, humanitarian organizations. The community, sometimes it's with shelters, locally clinics. So it could depend more on the communities, and it also can include many more, I would say, actors into the whole surveillance systems. These signals are not always connected systemically, and let's say the national surveillance system structure sometimes is, I would say, could be very rigid and is not, let's say, providing an access to everyone to provide inputs or also to be flexible regarding the management of the cases and the management of the signals. Maybe also another gap is that we often detect individual cases without fully detecting the pattern of movement or connecting those cases. For example, let's say cases may appear in several locations and be recorded separately by different facilities or institutions. Because, for example, let's say in the health system in Jordan, it depends on the public health services, in addition also to Royal Medical Services, private sector, sometimes a humanitarian, I would say, organizations, sometimes also. So it is a kind of, I would say, complicated health sector with a lot of actors that are actually impacting the whole process. So unless mobility history is collected appropriately and information is linked across systems, authorities may not immediately recognize that these cases are connected to each other or actually to the same route, gathering point or workplace, or let's say a population pattern. And also it could be a cross-border event sometimes without even noticing that. To simplify it, like many times it happened that there were, let's say, scattered reported cases of similar symptoms that are happening in different locations. But when we actually investigate, when we go back to the source, most of the time they share something. They have something, let's say, as a kind of cross-cutting event, either at the border, even sometimes before, let's say, reaching to the border. So usually there should be a kind of better, I would say, system that can catch the cases in such situation. Also, let's say another maybe blind spot is the continuity of care and follow-up. Unfortunately, most of the time when a traveler or a person or people, let's say, move in general, when they identified at the point of entry, they are referred to a facility, a health facility, and most of the time they get referred to another, I would say, let's say maybe comprehensive or tertiary health facility. But at the end, they will move to another governor. They are not going to stay at the border. So most of the time, most of the cases are lost. And we are dealing with surveillance events or surveillance signals as specific signals without actually focusing on the follow-up and the continuity of care, which makes the whole system sometimes inactive, or even if it's active, it's not going to be as impactful as it could be if we also catch the continuity of care and the follow-up. I don't want to go like with more details, but mainly there are sometimes also indirect health threats linked to displacement. In general, we don't focus on displacement usually when we are building our health systems, but displacement and mobility is a kind of very important actually factors that are impacting the health sector, impacting the host communities, and also, let's say, impacting the population in general, especially when we take into consideration the vaccination and let's say some of other threats that also impacts the health status of the people on move, like let's say having some poor sanitation, food insecurity, environmental exposure, and the mental distress that is also most of the time is being missed. The last point is that most of the time, or let's say most of our surveillance systems in the whole region, including Jordan, are institution centered rather than mobility centered. We are building the systems to be, let's say, part of the structure that we have, to focus on the point of entry or to focus on the health facility near to the point of entry, and that's it. But we don't build the structure of the surveillance system to be dealing with people on move, or to be, let's say, more focused or centered to the population and the mobility of the population. So most probably that is also impacting the whole process, the whole structure, and also the whole health system at the end. And let's say the deeper problem is that the surveillance architecture also is not consistently following the epidemiological reality of the mobility. The epidemiological component is also centered, or let's say focused on the structure of the health sector without taking into consideration, let's say, that the population mobility is the main factor that is impacting the let's say, health surveillance in general. And this is actually what we experienced during the pandemic. And we all noticed that the virus was crossing the borders much easier than, let's say, everyone expected. And that's what actually outbreaks and the public health threats are doing naturally. And this is what we need to be expecting. My conclusion is that, let's say, a border is an administrative line, but epidemic risk is a network. Until surveillance systems are, let's say, designed around the network, and let's say important early warning signals will continue to be missed, and that the surveillance system will not be 100% active. Thank you, Jafar. Back to you.
Thank you, Dr. Mahmoud. Dr. Muhammad, what Dr. Mahmoud describes as a relatively stable host country setting, and it became far more acute in a country operating under active crisis conditions. If you want to take Sudan as an example, it has been confronting active conflict, mass displacement, epidemic risk at the same time. At what point did the formal surveillance system cease to function effectively at the border, and what mechanisms emerged to replace or compensate for it?
Assalamu alaikum. Good afternoon. Thank you, Dr. Jaffer. Thank you, Dr. Mahmoud Migdadi. Actually, I'm very happy to join this webinars and panel. It is very important for us as Sudan. And Sudan, as you know, it is affected by this war. The big problem now, maybe all you know, the Sudan is affecting. Did you hear me well, please?
Yes, Doctor.
Okay. Sudan affecting by this war since decades. Previously, it was tribal conflicts, but now it's affecting all over the country. And up to date, most of Darfur and Kordofan, regions, around 5 states in Darfur, Greater Darfur, and Kordofan is non under government authority. Most of this under rapid force military. This affected actually the health system. This is just introduction of Sudan, as you know. I'm not need you to go through that because all Sudan is affected by this, and even the neighboring country. Definitely, this is war and conflict affected the health system, disrupted health system in general. And Sudan actually, before this war, actually it is for decades affected by the wars and tribal conflicts in the most border countries in the southern before Sudan to divide it into two countries, Sudan and North Sudan and South Sudan. It become the newborn country, and nowadays is ongoing conflict in the western part of Sudan. Thank you for choosing Sudan as example for the unstable country, and definitely the impact it will come for the health facilities, serving the populations, and even the health cadres become like a victims, and it's affecting for brain drain for the people to go out country or move from their places to other places. Sudan, actually, it is not all health facilities covering by surveillance system is a routine work. Actually, it is doing like indicator-based surveillance in the health facility, like Sentinel site already selected as surveillance system. This system, it's around more than maybe in the last 70s, 1970 or something like this. And gradually, year by year, is expanded to include a lot of health facility due to growing of population. Right now, it's around more than 2,300 health facilities under surveillance system. It's consists of like 38, less than 40 of total health facilities. Now it is reporting their health facility at health system in the country. To be include all health facility around 6,393. It includes hospitals and rural hospital, teaching hospital, and health units, basic health centers, family health units, and so on. During outbreaks, actually, it is moving from sentinel-based surveillance system to indicator-based surveillance system to zero reporting to cover all health facility. Actually, this is affecting the system, as I said, during this war, and to capture, because the surveillance it is like information for action. It needs to be systematically and ongoing, periodically. Sometimes it depends of the outbreak is ongoing. If some outbreaks like a cholera or dengue fever or other type of disease, like a communicable disease, is required to be on daily basis to look what is the trend of the disease going on. So it needs to on daily basis. Then some area definitely is not covered by health facility. In that case, we use event-based surveillance system. Actually, established recently, before 10 years ago, around 2016, in Red Sea and White Nile states as piloting. Then during 2017, 2022, training more than 6,000 volunteers across the country. These trainees, receive the event-based surveillance guidelines, standard operating procedure, SOPs, and how to verification the signals. Then in the area of conflict, as I said, especially in Darfur region, it start like EWARS implementation, timelines in Sudan, EWARS system, early warning and response, established in 2004 after the conflict in Darfur. It started 2003, then to cover 5 Darfur states, because it is running by some NGOs, collaboration with partners, international NGOs, UN agency, and national NGOs working in the regions, and then reporting to the government. And this system actually up to date is functioning, but the problem is the completeness of the data, timelines of the data. Sometimes it not comes in the required time. As I said earlier, I mentioned is a very crucial issue of the surveillance system to give accuracy, valid data on right time to use your intervention as quick as possible to avoid, because our ultimately to reduce morbidity and mortality all over the country. Other types, actually, the issue of point of entry. This is now we are talking about, because disease no does not know in the boundaries or borders. It's cross border, because especially in Sudan, because tribal issue, relatives, especially between Sudan and western part like Chad, the same tribes. Maybe you're relevant in the other side in Chad or in Libya, or here in the south part in with, Central Africa or South Sudan, and here in Eritrea and Ethiopia, also in Egypt, in the northern part of Sudan. This is a point of entry, and designated point of entry is the problem of point of entry. Designated point of entry is very few according to very large space. People maybe move from the place to other place. Especially we are here, we are very happy because as IOM, they know exactly the figures. Millions of people of Sudanese move from their home as refugees to neighboring countries, and some of them internally, like gathering points or asylum seekers, or some also for traditional mining come from their other countries, like from Niger, from Mali, from western part of the country, come to our country in traditional mining, in the gold mine. This actually create a lot of problems like respiratory infections, diarrheal disease, waterborne disease, and so on. A lot of issue. This is actually, it needs a lot of matter of like a Gambia project is Egypt, is agreement between Sudan and Egypt, but it's only focusing the vector-borne disease, especially malaria. In the northern part, it covers 3 states. It is donated from workers and from Sudan side. It is very effective and very good exercise within 2 countries. And also recently we have programs with South Sudan during refugees and returnees. We have a lot of settlement in the White Nile State, becoming the South Sudan border, in Joda border. A lot of people come from like returnees, because as I said, they're relative here and there with South Sudan, and come with thousands of people. It's not just hundreds or few people. Every newcomers, then we in the entry point and conducting vaccination, OCV, oral cholera vaccine. It was very successful scenarios, and it's good experience. It is immediately leading to reduction of the house, go through White Nile, Sinnar, and as I said, the final destination in the Blue Nile state, going through very large and very risk area. This is actually led us to make like following their roadmap and how we are back control the disease.
So, for example, here with this point, I'd like to, it's actually happening on the ground, but maybe we can imagine a country identifying an outbreak of zoonotic diseases affecting its livestock. And they want to share that information as rapidly as possible because that is the right public health decision, right? But it might also lead to neighboring countries that they work with or they trade with suspend the livestock imports. And even after they say that the outbreak has been controlled, they might, as a precautionary measure, extend or keep those trade relations suspended. So for countries whose economies depend heavily on livestock, for example, there's this difficult balance between protecting public health and also protecting livelihoods in these countries. Another one, so this is the first one, which is governance and building trust. Another challenge, I think, is sustainable financing. So cross-border surveillance and pandemic preparedness often receive a lot of attention and a lot of funds during emergencies, and we've seen that in COVID-19, of course. But investments usually tend to decline once the immediate crisis is resolved. And our research found that implementing a true One Health approach, of course, I'm talking about One Health here because we have to recognize that many cross-border threats are driven not only by human mobility, but also by the movement of animals, vectors, food. And also, we can't ignore climate-related impacts that often extend beyond borders, of course. So the One Health approach requires sustained financing across multiple sectors, be it not only the health, of course, it could be the environmental departments, agriculture, the vet. Up until now, funding remains very fragmented. With animal health and other sectors, they receive less than the health sector, so they remain under-resourced, despite, of course, their importance or their critical role in preventing, for example, zoonotic outbreaks. So we should ensure that long-term domestic investments and clear financing mechanisms are always there to improve or support cross-border disease surveillance. And another one I think I'd like to mention, which is closely linked to the financing bit that I just mentioned, which is the need to invest in people. We often focus on strengthening surveillance systems, but we all know that surveillance systems are only as effective as the people who run it. And also, Dr. Muhammad mentioned the brain drain and so many other factors we saw across the literature and the interviews that we have shortages of trained epidemiologists, lab staff, especially with the secluded points of entries. We lack border health personnel and also surveillance officers. So this was really mentioned so many times in our work. And there is a very high staff turnover, which means that the countries, they always lose trained staff and must retrain new personnel. And this is really draining in terms of efforts and also resources in general. So when we ask why these gaps persist despite the years of evidence, I think now we need to shift from adding more reports, talking about the same problems over and over, and we need to move from identifying gaps to investing in systems through stronger governance, building trusted regional partnerships and sustainable funding. And interoperable surveillance systems because, for example, in Jordan, we have multiple parallel systems for different mobile populations. So having this interoperability is very important. And of course, to have the well-trained public health workforce. I guess these are the main ones that came across from our work. And I know we mentioned challenges, but maybe if we have more time at the end, I can mention some success stories. So back to you, Jafar, and hopefully we'll circle back to the success stories later on. Thank you.
Farah, of course, we'll be ending with you with the future directions for surveillance systems, and you can, of course, state some of the success stories. Dr. Mahmoud, we're gonna be back to you for our second round. Dr. Mahmoud, as you know, the international health regulations set clear obligations for point of entry and cross-border notification. However, in displacement settings, much of the epidemic risk move through informal routes and channels that the international health regulation framework I don't want to say it wasn't designed to address, but it doesn't give a worth to it. In practice, what would a surveillance system capable of covering these channels need to look like?
Thank you so much, Jafar. Actually, I will start from a kind of, let's say, a definition of the border health. Let's say, usually when we mention border health, It is actually on the ground, the health facility at the point of entry, and that's it. But the actual border health is not simply healthcare at the border. It is more, let's say, a coordinated public health system that follows health risks across the mobility continuum from the origin through transit and points of entries to destination, actually focusing on protecting the population health and also the individual's rights. Uh, a system capable of covering informal mobility channels would need to be distributed, layered, trusted, interoperable, and directly connected to response. The first principle is that it should be, let's say, mobility centered. As I'm getting, let's say, back to the first point, it needs to be mobility centered rather than checkpoint centered. If we keep, let's say, our approach focusing on the what we can do at the point of entry, it is gonna be it's working, but it's not gonna be the optimum approach, I would say. And of course, that doesn't mean let's say that we need to establish a health checkpoint along every informal route, because this is not doable. It's not feasible, and most of the time, it's not even desirable. So. I would prefer to go with the, let's say, the meaning of, let's say, identifying the broader mobility ecosystem, which has, let's say, a lot of actors and a lot of components, mainly, let's say, the communities of origin, the transit areas, the border communities, transportation hubs, also, let's say, informal settlements as well. Reception centers, and also destination communities. Also, I can say that it is one of the main and most important components of this ecosystem. The system also should monitor signals across the network rather than expecting all the risks to pass through one designated point of entry. We have been working since the pandemic in the whole region on the, let's say, health component at the points of entries. And to be very fair, like there is like I can mention that there are a lot of success stories and there are a lot of I would say achievements, but yet the systems that we are having are not covering a kind of approach, or I would say an optimum system that catches, let's say, all the risks and also focuses on the general health system. So there are several requirements on the health system or in the surveillance system that we are talking about. And let's say let's say the layered surveillance model is a main requirement to have a productive model. The formal or the classic indicator-based surveillance is very essential. It's very important, and it is serving the whole surveillance system on the national level and also the global level. The health facilities, especially hospitals and the healthcare provider centers, also the laboratories, the pharmacies, and everything, must continue a kind of reporting confirmed reporting system for the confirmed and suspected cases. But this should be complemented by a kind of, let's say, CBS and DBS, community-based surveillance and evidence-based surveillance. Otherwise, it's not going to be enough, and it's not going to be, let's say, serving the aim of the surveillance system in general. Also, it is worth giving or including in the mandate the community health workers, the local organizations, humanitarian partners, also private sector, including pharmacies, for example, primary healthcare centers. Also, let's say all the partners, all the components of the system should have simple and safe mechanism for reporting unusual health events. For example, let's say if we have a cluster of fever, rash, severe diarrhea, respiratory symptoms, unexplained deaths sometimes, which is most of the time it is recorded, but misdiagnosed or let's say misleaded in some cases, like what we experienced during the pandemic, during COVID pandemic all around the world. And also very important indicator that we don't usually focus on, which is the sudden, increase in health care demand, which is sometimes related to seasonal activities or events, but also most of the time it's not related, and we don't find explanations for it because we catch it very late. These reports altogether don't need to be diagnosed, don't need to be very comprehensive or let's say detailed. We can deal with them as signals that requires verification, and here comes the health sector role or the health system, the central health system role to verify these signals. Environmental and One Health information is very important and can also strengthen the system, as Farah mentioned previously, and also the changes in water quality, vector density, animal disease, sanitation conditions, or sometimes population concentration also may provide warnings before a major increase in human cases become visible. Also getting back to the requirement, the trust between the community and the health systems in general. This is very important and this is a huge need. And unfortunately, this is a gap in most of the countries in the MENA region. The informal movement cannot be understood only through a government system because many of the relevant communities may have limited interactions with formal institutions. Surveillance therefore needs partnerships with organizations, individuals already that are trusted by the communities. However, let's say community participation should not turn community members into immigrant informants. The purpose must remain public health protection because this is a very sensitive, I would say, intervention with a very sensitive consequences. People must understand that reporting illness will connect them to care, to services, to health systems, rather than exposing them to punishment or detention or deportation, or also maybe some other legal consequences. Confidentiality and the separation of health information from immigration enforcements are not secondary ethical consideration. They are operational requirements that need to be highlighted and also they need to be worked on so that the communities have this trust with the health system. Because without this trust, the system will receive incomplete or delayed information, or most of the time also is not going to receive the information which was going to impact, let's say, the response or let's say the management of the cases in general. Also, I would add another component, which is a minimal and interoperable information package. In such, as I mentioned, we are talking about signals. We are not talking about, let's say, cases that needs diagnosis when we are talking from the surveillance point of view. So in an emergency, countries don't need to exchange very detailed, let's say, every details from every patient record. There should be a kind of agreement on the minimum data sets or minimum information package that needs to be shared that actually answers the practical questions like what happened, where and when was it detected, what are the syndromes or the disease that we are suspecting, how many people may be affected. So let's say we can keep it general to the point that let's say it's not intervening with the security component, especially when we're talking about the points of entries. Because we all know, like in cases of emergencies, and also let's say specifically when we're talking about, let's say, migration or movement of people, and taking another layer of, let's say, dealing with the points of entries, most of the time it is really sensitive, and the security is being the first priority for the governments, and most of the time also for the people. So that taking that into consideration must actually highlight the importance of the health component, and let's say will make us focus on having the minimal information package that could be useful, let's say, for the cross-border data sharing and information sharing between the countries. Also, yeah,
I
sorry,
left.
did I take more
thought you,
time?
yeah, I thought you finished. If
No,
you
just
can conclude, if you
just
can
let me
conclude, yeah.
conclude. Yeah. Sorry for taking that much time. Let's say my conclusion is that, let's say, informal route surveillance should not attempt to place a formal border post everywhere. We can, let's say, create a network of trusted eyes, ears, response capacities around the places where people move, rest, and live. So this will be very useful, and this is going to strengthen the health systems in general. Thank you, Jafar, and sorry for taking
That's
so
fine.
much time.
Thank you, Dr. Mahmoud. Dr. Muhammad, Dr. Mahmoud have given us a picture of what the system needs to do. Now, I want to bring that to the most demanding end of the spectrum. In a crisis setting, what is the minimum that a cross-border surveillance system must be able to do? In other words, let's not think about the ideal model, but the essential operational baseline we should have.
Hello, Dr. Jafar. Thank you for very important questions. Hello, did you hear me?
Yes, we can hear you.
Thank you. Okay. You asked very valid questions, by the way. in the fragile or disrupted health system in complex emergency, especially in the case like Sudan. As I said, the Sudan is affected by this war, and some areas not the government is not good handling with that because, as I said, it is not accessible for formal government to go there. But some INGOs, international partners, they are working there through our early warning system or EWAR system. We're trying to, although the difficulties and the type of work in that conditions, it needs a lot of precautions and realistic movement. But anyhow, we have good collaboration and coordination with that partners. And we are trying also make a rapid response team. It's very successful scenario, especially in the areas not covered by health facility. Also through mobile clinics. It is not fixed. You go from place to other place. You know the type of health services availability. The HIRAMS, health resource availability mapping and monitoring system. It is very functionally in this area, especially in the conflict area, because it give us a complete pictures about the type of service availability, type of disease, the pattern of disease, especially for communicable disease as an international concern, and we listed as group A. This is the daily notification, or group B. Sometimes the issue of completeness, the issue of the electricity, the issue of networking at that area, it's not accessible. So we're trying to fulfill this gap by the rapid response team. Rapid response team at federal and state and sub. Hello?
Yeah.
Hello?
Yes, we are hearing you. Yes.
Yeah. Yes. This is very important for sharing information as quick as possible for interventions. We're trying to also train volunteers at the border village. Uh, this is it's not a formal information system, but like volunteers at community. As I said, it's very important for them to, if they have observe any unusual events in the area, immediately they're trying to communicate, and we sending team to for verification and to respond to that outbreak. But it's very important in the matter of the cross-border collaboration, the issue of to establish a platform for data sharing, coordination, and like EMRO and AFRO regions. Through them, we can coordinate a good platform for early warning and response mechanism. Also make an operation data sharing is very important as quick as possible. Also, the speaker before me, Ms. Farah, she talked a lot of very important points, like the disease is not come also passenger or population movement from place to other place. Also, is goes with their goods, their trade system, their environment. The issue of wash is very important. Wash infrastructure in the point of interest, the supply system at point of interest is we have to consider all these factors. It's very important, and make a prioritization for the event for public health concern with coordination with partners, especially IOM and UNHCR and UNICEF and WHO. Also mapping infrastructures and resources through human resources, what type of human resources we needed to fill, and we trying to fill it with a rapid response team to reach the very remote area. Information sharing, of course, is very important for modalities through meetings, through reports, radio phone, or using different tools for information sharing. Joint training between two countries is very important. Like also conducting simulation exercise is very important to accelerate to sharing information, because as you said, disease is not have small locations, maybe spread from other place to other place. Capacity building, we have also looking for capacity building between countries, because especially in Sudan right now, affected by this war and conflict. And even the health cadre is sometimes it's very difficult to them to go abroad. So we are trying to use as minimum requirement by any way to use this information with our partners, with HIRAM system, with EWAR system, with border village volunteers. They are sharing with their relatives, and we trying to collect this data for to make our operational plan or contingency plan for interventions to come back with control the disease. This is, I think,
Yes, Dr.
overview. Okay.
Thank you, Dr. Muhammad, for your valuable contribution to this discussion. Ms. Farah, we have pointed to population, refugees, IDPs, people crossing informal routes in general, that formal systems are not designed to see mainly. What does the evidence tell us about where early warning signals of epidemic risk among these population actually originate? And what does this imply for the future directions of surveillance systems?
Thank you very much, Jafar. So the evidence consistently shows that early warning signals often are received from outside traditional health facility reporting system, just like Dr. Mahmoud mentioned. We know that indicator-based surveillance is extremely important, but also we know that it's not really designed to capture highly mobile or underserved populations such as refugees, illegal migrants, for example, nomadic communities in certain countries, and those who informally cross borders. So instead, we see that the earliest signals frequently originate through community health workers. It could be humanitarian organizations, as my colleagues referred to. One important part is event-based surveillance. That is a big part of what we do in certain MENA countries, including Jordan. Labs, vet services, environmental surveillance, and of course, one big part is through local community networks that can usually detect unusual health events before they appear in routine reporting systems. So this really highlights the importance of expanding surveillance beyond hospitals and clinics to include community-based and in general multi-sectoral sources of information. Also, I think that the evidence suggests that the future of surveillance is not just about creating new surveillance systems, parallel surveillance systems. As part of our work, we saw that almost all the countries we looked into have at least one or more operating electronic surveillance system. But now what we need to focus on, I believe, is the integration. We need to better integrate existing sources of information. So preparedness increasingly depends on connecting EBS, event-based surveillance, to indicator-based surveillance, lab data, genomic surveillance, water surveillance, or environmental monitoring in general. And overall, we need to have like that one health system that supports timely decision making. I know that is sometimes not very feasible given, again, one of the challenges we mentioned, which is financing. But we think it's extremely important to have this integrated approach that allows countries to verify signals more rapidly, detect outbreaks earlier, and also respond before transmission or widespread transmission occurs. Also, I think Dr. Muhammad referred to this briefly. We think that technological advancements or innovations, we need to really dig deep into this. It offers an important opportunity to strengthen cross-border surveillance. So from our review, we identified several promising approaches, including mobile applications that were, I think, used for refugee health. It could be genomic sequencing to characterize emerging pathogens, mobile phones, the use of mobile phones and mobility data to understand how the population moves. Also blockchain technologies for secure cross-border information exchange, especially in mass gatherings, or if you remember during the COVID-19, we had so many forged tests. So blockchain technologies can be used to prevent those. And again, digital tools used during mass gatherings. I believe in Saudi Arabia, they try to use smartwatches to improve traveler surveillance. So while technology is really important, it's alone, of course, this is not enough. Many of these innovations are isolated pilots, or they operate independently of the national surveillance system. So the priority moving forward could be to scale up those proven innovations, ensure interoperability between the existing national systems, and implement them in ways that protect the privacy of people, especially those that are very vulnerable, like refugees, while supporting the country-owned surveillance systems. Before I end, I also wanted to mention, because in the MENA region, we have so many challenges, so many gaps, but I want to mention two quick examples really quickly about partnership, which I think are important to highlight, is the Gulf Center for Disease Prevention and Control, the GCDC, which is considered a successful regional network for information sharing, where the Supreme Council of the Gulf Countries Corporation approved the establishment of it in 2021. And it serves as a regional public health center aimed at strengthening public health coordination, capacity building, and evidence generation in the 6 member states of the Gulf: Saudi Arabia, UAE, Kuwait, Qatar, Oman, and Bahrain. So it was interesting to see that during the COVID-19 pandemic, all these GCC countries followed health policies and guidelines recommended by the Gulf CDC, such as lockdowns, travel bans, and other restrictions. And up to this day, when we did the interview, we know that they still maintain this network, and for the member states, of course, where they meet on a weekly basis. They have nominated focal points from every country, whether it's from the IHR focal point or lab or surveillance, and discuss and share information whenever needed. I know this is for high-income countries, but also Dr. Muhammad mentioned Sudan's collaboration with Egypt, but also I think it's another success story. Maybe Dr. Muhammad can also talk about this a little bit more if there is time, is Sudan's geographic position, where they neighbor 7 countries, I think, and they're all affected by conflict, population displacement, and they have fragile health systems, which makes disease surveillance or cross-border disease surveillance a challenge. Sudan convened a regional meeting in 2018 that resulted in the Khartoum Declaration that was signed by multiple countries: Sudan, Libya, Chad, South Sudan, Ethiopia. And I think this declaration established like a common commitment. That's what we were talking about, the political commitment to strengthen cross-border collaboration, improve information sharing, and enhance coordination for public health emergencies. And when we also worked on the literature, we didn't see any formal evaluation of this declaration and the impact, but we think that it's a significant step toward committing to regional dialogue and collaboration, and also highlight the importance of IHR as the main governance framework that we work with. So this experience just highlights that strengthening cross-border surveillance not only requires the technical aspect of it, but also the sustained political commitment, regional trusts, and mechanisms to translate agreements into routine operational collaboration. Thank you.
Thank you, Ms. Farah. I just want to remind our participants that the Q&A box is open. If they have any questions, they can add it. Meanwhile, I want to thank all of you, Dr. Mahmoud, Dr. Muhammad, and Ms. Farah, for this grounded and evidence-informed conversation. What this panel has showed us is that the gap in cross-border surveillance is not a technical problem. It's a problem of reach, of system designs for population that stay in one place, trying to track diseases that move with people who do not. The populations we have been talking about today, from refugees to IDPs, people moving through informal corridors, are not at the margin of epidemic risk in MENA, they are at the center of it. And as of today, they remain somehow invisible to the systems we rely on for early warning. That is precisely what our next panel begins. We will be having a second panel that will take us deeper into the blind spot, focusing on community-based early warning surveillance and asking how we build surveillance that actually reaches the populations this panel has shown are currently off the map. We thank all participants for being with us. We'll be just waiting 2 minutes if anyone have any questions. Okay, so we have a question from Dr. Sheikh Al-Shotari. I want to know any success stories in surveillance the informal cross borders. So he's asking about any success story other than what Ms. Farah stated.
I can actually, let's say, start if you want, Jafar.
Yes, of course.
Yeah, actually, I would start from the experience of the Syrian people who actually were forced, let's say, moved to Jordan through the Jordanian-Syrian borders, not the points of entries. Actually, let's say during that period, talking from, let's say, 2011 until maybe, let's say, further on, it was a kind of, there were several success stories focusing on the inclusion of the, let's say, near border communities that were part of the support systems, in addition to, let's say, the involvement of the private sector, also the or international and local NGOs that were supporting, and also the inclusion of different factors and the cooperation from the governmental side into let's say, providing the services, and at the same time detecting any expected public health threat, whether it's a disease, it's a syndrome, it's a group of, let's say, symptoms, whatever it was. There was a kind of informal surveillance system that was depending on everyone dealing with these people who are actually crossing the borders. Actually, it was a WhatsApp group. And almost like in every single discussion that we are having recently about surveillance system, it is being mentioned because everyone has the ability to report, and everyone has, let's say, the access to this group, and these reports or these signals were taken into consideration from the governmental side, from the central level, and they were being investigated and dealt with in a very, let's say, a short period of time. And that led to a lot of cases that were managed and they were dealt with during, let's say, the process, because it was a kind of humanitarian action, and also that impacted the whole, let's say, health system in general. And without the involvement of the private sector and the, let's say, organizations and the communities around the borders, it was impossible for the rigid national health surveillance system to be able to catch these cases. Thank you.
Thank you, Dr. Mahmoud. We have one more question from Muhammad Awadallah. It's for Dr. Muhammad. If he could tell us more about his experience in Sudan from the collaboration with Egypt as an example of cross-border surveillance, and if he can tell us more about the impact of this experience.
Okay, thank you, Dr. Jahfar. Thank you, Dr. Muhammad Awadallah, for your very nice and very important questions. As collaboration, started with Egypt. As I said, from our experience, since long period of time, I said in 17th, the Gambia project is collaboration, these two projects, especially focusing for vector-borne disease, mainly in malaria, because malaria in Sudan, it is a high burden of disease leading to morbidity and mortality. And this is project eliminate the malaria in the northern part, especially in the north state at that time. Actually, this project stopped 2014 due to many factors, but now we are already activated with more than maybe 500. I'm not exact the numbers of the dollars allocated for this budget, but it's very huge amount for the money, and expanded to 3 states: River Nile with high priority localities, River Nile, Kassala, and northern states, the area border with Egypt, to eliminate and also supported with insecticides control and entomological surveillance. Also, it's not just disease surveillance. As I said, it's mainly for the vector-borne disease, and within the vector-borne disease, focusing in malaria. But we are when you know residual insecticides is control or insects that is maybe make hazard for the disease transmission. This is one issue. The other issue, Egypt, Jazakallah khair, thanks for them. They are hospitalized a lot of our people, millions of people, Sudanese people. They are during this conflict. They are moved to our second country, Egypt. They stay there for maybe some of them still there. Some of them are returning back to Sudan, and in the Ishket, Aswan, and Argin, and this is also designated point of entries between Egypt and Sudan. They have mobile clinics trying to investigate and make triage and screening for the people for few disease and sharing information, the issue of laboratory investigation. This actually it is reduce a lot of overburdening of disease, and still we are this few months, maybe start coming October, we activate the same project. It is good for collaboration and coordination with cross-border mechanism between Sudan and Egypt. And also, I said the example is very live during last outbreak of cholera. Already declared Sudan is free of cholera, but it was very successful scenario. Those people come from South Sudan as returnees. We classify people as nomads. Nomads, those people. Maybe Dr. Magdadi knows this with IOM. We are classified as people. Nomads is representative 18% of the population, especially in some areas come from remote and here is the animal resources. And we are very happy to hear from our sister Ms. Farah about One Health approach. Also, it was very approach and platform. It's very successful with environment, with animal resources, with health. Three ministries are collaboration together and making agreement for their sharing. And as I said, OCV, it was very successful scenario recently during cholera outbreak, especially in the refugees and returnees and IDPs in Sudan. Thank you.
Thank you, Dr. Muhammad. Thanks to all of our participants. We don't have any more questions. Thank you again, Dr. Mahmoud, Dr. Muhammad, and Ms. Farah for joining us today. This marks the end of our first panel. We look forward to welcoming you again in our panel 2 and 3, and have a wonderful day ahead. And thank you all again.